Enteral and parenteral nutrition. The objectives are to compare and contrast the patho, signs and symptoms, and treatment for GI nutritional disorders, discuss nursing care of clients with GI nutritional disorders, differentiate and explain enteral and parenteral nutrition, and use the nursing process to care for a client with nutritional disorders. In essence, we're going to continue nutritional discussion, and at this point, it will be through the process of enteral feedings. An enteral feeding, or enteral nutrition, is provided through an intact GI tract distal to the oral cavity via a tube, catheter, or stoma. In other words, we're still using the GI tract, but we're bypassing the mouth, and it may be the neck or esophagus. It has cancer or trauma or something, and we're bypassing it, but you have to have an intact GI system in order for the nutrition that's being given in this tract to be effective. Interestingly, people can usually tolerate a lack of nutrients for about 14 days, but they have a better chance of recovery if there's early feeding. And that's one of the reasons we would give enteral feedings. So the question at hand is, who is a candidate for enteral feedings, given the definition and criteria that was just stated? Well, maybe someone that has head or neck cancer or even upper GI cancer. You can bypass the stomach and give feedings directly into the intestines. Or someone with critical illness that's too weak to feed themselves. Someone with neurological and muscular disorders, brain disorders, stroke patients, dementia patients, myopathy patients, people with Parkinson's disease, all might be a candidate for an enteral feeding. Other GI disorders like enteral cutaneous fistula or irritable bowel disease, mild pancreatitis. Someone with respiratory failure that has a prolonged intubation for respirations, or someone that's just had a local trauma, or has anorexia nervosa, has difficulty chewing or swallowing, and even severe depression. So all could be a candidate. You're familiar, you've watched videos, and we've talked about it in Skills Lab, but just as a brief review, enteral feeding is provided through a nasogastric tube, or the more generic term is the nasoenteric tube. When we do a nasogastric tube, specifically from the nose to the stomach, that's anticipated to be short-term feeding, at 6 weeks or less. I've even heard 2 weeks or less. Bottom line, it is short-term, not someone that's going to be chronically for months and months fed because of the risk of aspiration. Another category of enteral feeding is the nasointestinal tube. So I have a picture there, if you look, of a nasogastric tube, and that's considered a tube that goes through the nose, down the esophagus, into the stomach. But a tube that had a longer length, that's kind of redundant, but the tube is able to reach into the jejunum, would be considered an intestinal tube, or even into the duodenum. Gastric tubes are tubes that are inserted directly into the stomach. So the pictures you can see here, there's a tube. The site of entry is the stomach, and that particular tube goes into the jejunum, past the duodenum, and then into the jejunum. A gastrostomy tube would be a tube that went just directly into the stomach. And then finally, different than that tube piece sticking out is what's called a gastrostomy button. And so again, directly into the stomach, as you can see, but you don't have the long appliance sticking out. These tubes are lovingly called PEG tubes, and that's because they were inserted percutaneous, that's skin, endoscopically. So a tube was put into their nose to visualize the insertion and location, and then gastrostomy into the stomach. So then the nasal camera is removed and the tube is left directly in the stomach. So they're just called PEG tubes, and that's really the technique for putting them into the client. You know how to verify placement, but just to review, one of the most critical parts of care for nasogastric management is that whenever a tube is originally inserted, it needs to be the placement needs to be verified by X-ray. Air installation, putting in 20 milliliters of air and listening at the stomach to see if you hear it, is contraindicated. And in fact, I don't even think your book mentioned it as an option. pH, or gastric aspirate, is another method. And so a pH less than 6 in some materials, sometimes it's a pH less than 5, so 4 or below, is an indication of being in the acidic stomach. The hydrogen chloride activates the pH strip. Or you visualize aspirate. I mean, if you aspirate the residual, what's left in the stomach, and it looks like the milky product, the insure, or it's the green bile, then that's a good sign that you're in the stomach. One of the terms that's used to refer to the aspirate is called the gastric residual volume, the GRV. And it should be checked every 4 hours for 48 hours, and then every 8 hours when people are getting feedings. If the GRV is greater than 250 milliliters twice, you want to consider some pro-motility drug. In other words, something that will encourage peristalsis, to move those feedings out, because it's just stagnating in the stomach. If it's more than 500 milliliters, then the feeding is stopped because they're just not moving the fluids through. Another way of verifying for placement is the length of the tube, and that would be the length from the end of the nose to the end of the tubing. If the length increases, that means the tube has migrated and it's probably not in the stomach anymore. If it's shorter from the nose to the end of the tube, what's external, then maybe it's migrated into the client some more. So re-verification by X-ray may be required. Visualizing the tube in the throat's a good sign. Sometimes that tube can coil and come out the mouth, so seeing where that tube is. And then a relatively new way of verifying placement is through carbon dioxide monitoring, or capnography, and it's a way to verify that it's not in the lungs. So if it's in the lungs, then the carbon dioxide of the lungs would change or give a reading, depending on if you're doing it electronically or if you're doing it through pH paper. But one way or another, it verifies that it's not in the lungs. It's not perfect for saying it's not in the stomach, but for sure it's not in the lungs. And so that's another method that might be part of hospital policy. I just thought I'd show you a picture of a couple of cases where the feeding tube was put into the head, and nurses had verified that they had checked for placement by putting air into the stomach, and they heard it. Well, you can see they were mistaken because that tube was clearly not in the stomach. So it's contraindicated to even put a feeding tube or an NG tube into a client that has had a broken nose or has some other physiological breaks or cracks after a surgery, where it puts them at a higher risk for the tube not being into the stomach. So it's just critical that the first verification is by X-ray before any feeding is ever done. Best practice for enteral feeding tubes, according to the American Society for Parenteral and Enteral Nutrition, known as ASPEN, is that when someone's getting a tube feeding, that all the bottles, bags, syringes, tubing, everything needs to be labeled with the date and time that was hung, because things need to be changed based on the product that's being used. And so everything needs to be labeled so that it's replaced appropriately. Tubes need to be flushed every 4 hours with 30 milliliters of water. And the water should be purified, sterile water. Tap water is okay if they're not immunocompromised. But if they're a cancer patient or an AIDS patient, for example, they need to have purified, sterile water. And that's what we're using most of the time in the hospital. Distilled water is not okay, so don't consider that. Hang time for tube feeding should be 4 hours if it's a reconstituted, some powder that's been made into a liquid, then only 4 hours. 4 to 8 hours if it's a can or open to air. And then if it's a closed system that's from a manufacturer that's in a closed sealed bag and has its own tubing, then, or it's just a bag and it gets connected to some kangaroo pump tubing, it can hang for 24 to 48 hours depending on the manufacturer. So it's really important that we know what their guidelines are. The client should be at a minimum of 30 to 35 degrees, and better yet 45 degrees with tube feeding going in, especially if it's continuous. If they're intermittent or bolus type feedings, I like to set them up as a nice 90 degrees if they can tolerate it, to help prevent aspiration. There's all different types of enteral feedings. I believe I got this list in particular from your key pharmacology book. There's palmeric, which are milk-based or lactose-free type formulas. There's modular formulas, which are single macronutrients, so it could be just protein, or it could be just fat, or it could be just carbs, kind of a thing. Elemental products are pre-digested nutrients, and then specialty formulas can be created for people too. I had a baby I took care of when I first started nursing, so a while back, and we fed her a formula that had been created just for her, and it was just referred to as 4242A. It smelled awfully much like soy, but I really don't know. It was made especially for that baby that didn't have villi in her intestines, and so she needed a really gentle formula, and that was what was made especially for her. There's different types of modes for delivery. There's the bolus feeding, and that's where you take typically for a bolus 250 to 400 milliliters of formula, and it's instilled through a syringe or through a funnel, and that's usually done 4 to 6 times a day, and it's over like 10 to 15 minutes. And that kind of patient is usually ambulatory and fairly healthy. They just have some reason that we're needing to bypass their head, esophagus, or something. So they get a bolus feed, which is similar to an intermittent feeding, but the difference is that a similar volume, 300 to 400 milliliters, is given over 30 to 60 minutes through a gravity drip. So it makes it a little bit different than just kind of pouring it into somebody. A continuous feeding is for critically ill clients, or feedings that are through the small intestine, and they're usually run at 50 to 125 milliliters per hour for 24 hours. The feedings go into the intestine, and again, less risk for aspiration. Those are given by pump typically. And then there are cyclic infusions, which are given over 8 to 12 or 8 to 16 hours per day. And a lot of the time they're given during the nighttime, so that during the day the client may be trying to do some oral feeding or having some freedom from the tubing and able to get up and get around. But there's a good 8 hours of break from the feeding itself. With all those continuous feedings, remember that head of the bed needs to be elevated at least 30 degrees, and as much as 90 if possible. When someone's getting a tube feeding, there's a lot of risk for aspiration. So we need to be really careful and watch for things. Silent aspiration would have symptoms like elevated respiratory rate or elevated temperature, their O2 sat decreases, and maybe even a change in vowel sounds. So really important, keep the head of that bed up and be watching for signs of aspiration, even coughing. Sometimes there's some intolerance to the feeding itself because it's maybe a higher glucose load than the client's been used to. So there may be some diarrhea, nausea, vomiting, cramping. And in that case, the rate may be slowed a little, or the feeding may be started slowly to prevent that from happening. And feeding's room temperature versus cold to prevent the cramping in their stomach. A tube may be dislodged or fall out, which would require replacement, which again is traumatizing to the tissue. We'd need a doctor's order. You just don't put tubes back in. Physicians need to be notified because we have to get X-ray verification again, or radiography. Tubes can get clogged up, so they need to be flushed every 4 hours with at least 30 milliliters of warm water. And water is the best solution of which we would try to flush a tube. There are other things that can be used if people are approved or certified, have to have a doctor's order for like pancreatic enzymes to help unclog a tube, but whatever, it's per hospital policy. You should never force or apply a lot of pressure when flushing, but you should use a syringe and like I said, 30 milliliters of warm water. Refeeding syndrome, we want to avoid that, and that's sometimes they call it dumping syndrome, where the stomach just doesn't tolerate the feeding. And so making sure that we're giving feedings appropriately and small amounts continuously so that they don't get overfilled. And then there can also be serum electrolyte imbalance as well from feedings. Maybe they're not getting enough or too much, or how their body's tolerating it. So things that we're wanting to watch all the time, INO, their labs and so forth, to see how they're tolerating the feeding. And just to revisit the idea of giving medications per nasoenteric tube or gastrostomy tube, you have to have an order for that. You want to give liquids whenever possible. Check with the pharmacy about crushing meds. Can the meds be crushed? And if they can't make solution themselves in the pharmacy. The meds should be mixed with 30 to 50 milliliters of warm water, but I would just mention that if you're giving a lot of meds at one time, you might want to go to 15 to 30 milliliters so that they don't get overfilled with the med, because you give the med, then flush. Every med is individually administered, so you can really fill a client up. So you go to give the med, you elevate the head of the bed, check for placement always first, then flush with water, give some med, flush with water, give some med, flush with water, and the last thing is always flush with water. You want to flush that med out of the tube. Don't mix meds with formula or other medications. Don't administer sublingual or buccal or sustained release tabs or capsules per the tube. Never crush enteric-coated meds. And you want to never reclamp the tube after med without flushing. Gotta flush last, get that med out of the tube. One, they won't get the med if you don't, and two, the med will clog up. And then finally, just to evaluate when you have a client that's on enteric nutrition, you need to be monitoring their weight, need to be monitoring labs, electrolytes, but even their albumin, which is their protein status, and see how they're doing. What's their caloric intake? Are they getting enough calories via the nutritional source? And changes don't always occur quickly for people nutritionally. Think of when you wanted to put on weight or lose weight or whatever. It doesn't happen overnight. So you want to be just watching them and educating the client on how to monitor themselves. And find out what the client's expectations are. Are they competent to do their own care, and are they giving accurate care? Are there any discrepancies going on between what nursing is performing and expecting and what the client is? And then work closely with the client to set realistic expectations and help them achieve their goals and to give themselves quality care. All right, well, we'll talk more about that, enteral nutrition, when we're in the classroom. But if you have any questions about any of that, bring them to class and we'll talk about them next time.